Bobby's been a member of the New York City Board of Corrections for the last 5 years, a position that's appointed by the New York City Council. He also serves on the editorial board of the International Journal of Prison Health Care and as an American Public Health Association invited observer of the World Health Organization European Region Health in Prison Project. He is a nationally renowned expert in prison health, and it is in that vein that he comes to us today. He also serves as a medical expert and is a monitor for the oversight of medical care in U.S. prisons, not just in New York, but in Michigan, Illinois, Ohio, New Jersey, Connecticut, Philadelphia, Washington, D.C., and in Florida. But Bobby is even though we were contemporaries, Bobby is one of my mentors. When I went to medical school, I was very naive politically, believe it or not. And it was Bobby and a group of medical students that came together first at Rutgers and then at Rush Medical College that really got me oriented towards the political underpinnings of all of the work that we were doing. And it was through readings that he would bring in and other colleagues and other things that really sort of put my training in a context that I think really set a path for what's been a whole life of political activism and has led to a lot of the things that we do. So he and I haven't been in close touch over the last years, but it's great to have him here today, and I'm sure that you'll understand why he's played such an important role in my life and has done so many incredible things. So without further ado, Bobby Cohen.
Thank you very much, Neil, and welcome everybody. It's a pleasure to be here. I'm going to not exactly cover every theme that was mentioned in some of the handouts, but I'll try to cover issues about prison health care in the United States, and I'm going to not provide an arc of TED Talk proportions. I think life is more complex than that. I'm going to talk about some contradictions within the science of correctional health care, and I'm going to be available for any questions. I have a few too many slides, but please feel free to interrupt me for any questions you have. So I just want to begin. This is the slide that you have to start. One should start every prison health lecture with the understanding of how weird we are, how out of joint the United States is. How this was a set of data that you were collecting, that if you saw the United States data, you'd throw it out because it doesn't fit within the within civilized means. One would say. So the notion that our rate of people incarcerated per 100,000 that's in jails and in prisons is the number that is used epidemiologically. And as you can see in this small slide, the U.S. is, if you took the U.S. population of people in prison, the rate, and you cut it in half, and you cut it in half again, and you cut it in half again, you would end up with a sort of Germany-France rate. So 1/8 would get you down to their rate. So when we think about the problems and solving the problems and the consequences of mass incarceration, these are not necessary problems. You don't have to do it this way. It becomes incredibly difficult to engage any of the issues around prisons because of the volume of people involved. But it does not have to be that way, but it is. And again, that was an example of some exceptionalism of the United States, and this slide just demonstrates that it also doesn't have to be that way. I mean, we had a rate of incarceration which was extremely low for the period from 1925 to 1975. I mean, it just really was tiny. And the population of the country, I forget what it was in 1925. Anybody know? But the incarceration rate just stayed very, very, very low up until the 70s, and Some of us here lived through this, others didn't. There are all kinds of explanations for it. You can make them up. There was the war on drugs. There was 3 strikes, you're out. There was the Nixonian period. There was the Rockefeller drug laws, which are mimicked all over the world. But again, it doesn't have to be this way. And as you can see, this curve, this number is 1.57. That represents people in state and federal prisons. There are another 750,000 people in jails awaiting trial in the country. And as you can see, this curve is moving in the right direction right now, very, very, very slowly. But it is not going up anymore. It's actually coming down, and that's either due to the serious political work that we've all done, or the increased cost of prisons. It's hard to say it's a cost issue because the cost was never an issue when it went up during that period, and there were recessions from 1975 to now, but incarceration rates continued going up. This is sorry, the slide's a little bit old, but it basically shows you that there is race matters in incarceration, and the chances of being incarcerated are 6 or more times greater if you're a black man than a white man, and 8 or 9 times greater if you're a black woman than a white woman. This is another epidemiology slide, and this shows that while during this recent 10-year period, that the number of arrests of juveniles went down in the United States, the ratio of black to white arrests did not change. So the system was moderating its behavior, but the racial disparities within the system stayed the same. And this is a slide this is data that just came out, even though it only goes back to 2009. But this talk a year ago or 2 years ago was a talk. The epidemiology was just everything was still going up and everything was going in the wrong direction. But interestingly, in terms of women prisoners, the rate of incarceration is going down substantially for black women relative to white women. So if you put the slide this way, this is quite a dramatic difference. On the other hand, if you look at the rates of incarceration, you see that the incarcerations of black women are still 3 times the incarceration rate of white women. So although the trend is clearly extremely positive, the actual the situation still has dramatic racial disparity. And another change, right? I mean, I don't know what you all think about this, but there's some notion that drug policy has been the driving force in mass incarceration in the United States. It's definitely been a large part of it, but as you can see from this slide, the percentage of people who are being incarcerated for drug offenses has gone down during the first 10 years of this of the century, and there's an increase in violent crimes. That's just of interest because a call for decriminalization, as I will call for, as a solution to some of the incarceration problem, does not engage the whole issue. And I think this also perhaps suggests that the real reasons for the racial disparity of incarceration don't necessarily have to do with any kind of crime or any kind of with any particular kind of crime, with drug laws, for example, but that there are other reasons which are not going to come out, which are not that easy to carefully, scientifically abstract, that have to do with why there are such dramatic racial disparities in incarceration in the United States. But even though we don't have a good scientific explanation, we have to engage it. So, huge problem. 2.2 million people in jail and prison in the United States, off the charts in terms of the rest of the world. That's the setting that I'm talking about. Now, this is a slide. I was involved in this case. I went down to Mississippi in 1999 for the American Civil Liberties Union National Prison Project, and they had been asked by prisoners who are HIV positive at the prison to help them. And actually, this is a case where there was an appointed monitor. In federal litigation, civil rights litigation, if you win a civil rights case and the state fails to do what it was supposed to do, If you say you're supposed to integrate a school system and the state does not integrate the school system, the courts can appoint a monitor who has substantial powers to move that along. Well, there was a monitor appointed in Mississippi who was a friend of the governor's to oversee prison conditions, and he was not helping the people who were HIV positive. In Mississippi, you got tested when you went into the system. If you were positive, you were isolated in a particular dormitory. You lived in that dormitory. You did not engage with other people, and you were started on DDC and AZT if you were positive. Now, I don't think, except for a few of us, have ever heard, have ever used DDC, and almost probably none of us have used DDC because it was not a useful drug in the treatment of HIV. But in 1999, it was clearly known that if you give two NRTIs for treatment of HIV infection, what you achieve is resistance to NRTIs. You do not achieve any significant benefit for the person. 6 months of benefit, but that's really all it is. And this was clearly known in 1999. And the medical care in the Mississippi prisons in 1999 was being provided by the University of Mississippi Medical School. And the medical director of the prison system was based at the medical school, and he was the head of infectious diseases at the medical school. But this was just a situation where the University of Mississippi said, we'll oversee it, medical school, we'll take 5% off the top for overseeing it, and they didn't go there and see what was going on. Every single doctor in Mississippi at that time was defrocked. They had lost their license for sexual misconduct, for financial misconduct, for medical misconduct, and they were allowed, however, to practice in the prisons of Mississippi. So they're given these two drugs, they develop resistance, and then after 6 months they're given a protease inhibitor. If they had given all of them at the same time at the beginning, then they would be where we are. But instead, they were given it 6 months later, so they all became resistant. And there was a trial in this case, and a prisoner testified in the trial that he came to jail. He'd been on 3 drugs. His doctor had told him never to stop taking any of the drugs. You have to take all 3 at once. If you can't get them, stop taking all of them and wait till you can get all 3. And he had written to his doctor when he was in prison saying, help me, help me, help me. And of course, his doctor was the medical director. So it was an interesting hearing, you can imagine, in court. And this actually turned around. So that had a positive response. This is 15 years ago, but it's important in terms of what the situation was. Now, this is another example of medical care in a Milwaukee prison, and this is a kind of presentation that you would that any of you would encounter here in New York. A 35-year-old woman, diabetes, hypertension, asthma, who has a psychosis. She asked for psychiatric care. She requested an abortion because she was pregnant, and she was becoming increasingly short of breath. Well, she couldn't get, the psychiatrist said, we can't give you any medication because you're pregnant. She was pregnant, but she was indigent and could not pay for an abortion. Her shortness of breath actually was not asthma, but it was recurrent pulmonary emboli from thrombosis, deep vein thrombosis, and she died. And this could be a story. This could be one of your patients mishandled. It wouldn't happen here, but here structurally the situation of the prison did not allow her access to care. Now, I'm going to move now to a discussion of a contemporary, topic of great contemporary interest, which I think is very important. Although I'll just bracket it by saying that when we talk about solitary confinement, which I'm going to talk about right now, everybody is against solitary confinement pretty much. It's not like motherhood, but there's a universal sense that we've done this. This is a very bad thing to do, and that is absolutely true. But I always worry whenever everybody agrees with you, maybe you're doing something not enough or wrong. So we just have to think about how thinking a lot about solitary confinement means that we're not thinking about other things in this area. So you can think about solitary confinement, which represents 4, 5, 6, 7, 8% of the population in prison, and that allows us psychologically to not think about the other 92%. That wouldn't be the case in this room, but it's a strategy of thinking that I recommend to myself and to you. It doesn't give you a lot of free time if you're always worried that you're not addressing another issue. But so, I don't know, how many of you have heard of the Pelican Bay prison? Pelican Bay is located in the northwest corner of California, just in the Redwood area, just below Oregon, and it is a relatively new prison. Maybe it's about 15 years old. It looks like a community college, and there are 3,000 people in the prison, and half of them are in solitary confinement. And there was a lawsuit brought on their behalf in 1995, which said that solitary confinement was a violation of the Eighth Amendment to the Constitution, cruel and unusual punishment. And a very, very progressive judge named Felton Henderson ruled that for people who had serious mental illness, that solitary confinement was extremely dangerous, and he ordered that they be removed from solitary confinement. He said that it was, well, you can read this, unnecessary and wanton infliction of pain, use of excessive force, to not provide inmates with constitutionally adequate medical and mental health care, and that they, particularly in solitary, did impose cruel and unusual punishment on mentally ill prisoners. That's the criteria in our Constitution. And so he ordered all of the seriously mentally ill prisoners out of solitary confinement. This is 1995, and that was sort of, that when cases got high into federal courts, that was the ruling in the United States at that time. And he wrote here, and I just put this all out because it's going to be important as I continue this vein, that conditions may well, on the SHU, Solitary Special Housing Unit is another term for solitary, is another term for the hold, is another term for punitive segregation, administrative segregation. There are some differences which I can discuss. They may well hover on the edge of what is humanly tolerable for those with normal resilience, particularly when endured for extended periods of time. They do not, however, violate exacting Eighth Amendment standards except for the specific population subgroups identified in this opinion. So what Judge Henderson is saying is that if you're seriously mentally ill, solitary confinement is so horrific and so dangerous to your health that you can't be there. But although he thought that solitary confinement was horrific, he did not have data, evidence, to convince him, even though he's sympathetic to it, that it was a violation of the Eighth Amendment, which basically has been interpreted as that it's actually causing harm to you. So all the people who were seriously mentally ill were taken out of Pelican Bay, and what was left were people who, another 1,500 people in solitary confinement, but not seriously mentally ill. I will come back to this. I was the I was the monitor for medical care in a group of prisons in Michigan called Jackson. At one point in the 30s, it was the largest single prison in the country. It was broken up over time into a few. It was a gigantic walled prison, like a James Cagney movie that you may or may not have seen. Five tiers of cells. Of note, when we were in medical school in Chicago, there was in the middle of this gigantic prison of about 3,500 people, there were two air-conditioned units. One was called Park Davis, and the other was called Merck, I believe, and they were both phase one pharmacy laboratories for prisoners. Were the leading source for phase one trials. And so if you volunteered to be in these trials, you got to stay in an air-conditioned unit in the middle of this facility. I won't discuss the issue of experimentation in prisoners. Those are down right now, and you can't see their footprints in the yard. But anyway, Timothy Souders, T.S., was I think he was about 19 years old when he was arrested for stealing paintball equipment from a paintball store. He had become increasingly psychotic beginning at about 16. He was a normal kid, as I understand it, as his parents, as his mother told me, as the notes read. And then his behavior became increasingly bizarre, and he had a number of run-ins with the law. He also had 5 suicide attempts, including running into traffic, an attempted self-evisceration, was on quetiapine. He was on clonazepam. He was also on L-thyroxine and hydrochlorothiazide and atenolol and one other antipsychotic medication. And he was sentenced to a couple of years for this paintball equipment theft. And in 2006, this is a mistake. This is August 3rd, 2006. It was the hottest week of the summer. After having been in solitary confinement before, he violated the rule of the prison, which was that he was on a restriction, which meant that he could not leave his cell unless he said, "May I leave my cell?" during a period when other people can leave their cell. It was a very, very, very hot day, and people were being encouraged by policy, which monitoring had helped to create, that people could get showers all day long when it was very, very, very hot, and they could have access to water freely. And he left his cell to take a shower, and which was a violation of the conditions of his being in this general population cell, and therefore the correction officers decided that, and they testified in court to this effect, that he's not going to learn anything by giving him another infraction because he's violating it anyway. So the only way we're going to be able to change his behavior is to put him into solitary confinement. So he was placed in solitary confinement, where he plugged up his toilet, so it flooded the cell, and because of that, he was placed in 4-point leather restraints on a concrete slab, and this is all on tape. Where I got a call on the 7th. I was planning on going there on the 8th, and I got an email saying that there had been a natural death that had occurred. I asked to be informed of all the deaths at the prison, and I went to the prison and asked to see the chart. And first day I was there, they didn't give me the chart. The second day I was there, I did get the chart, and I read this chart, and I cried when I read it. He was tied up for 4 days on a concrete slab. And medical staff came through every day and said, "How are you doing? Are the restraints too tight?" They gave him his medication, and after 4 days, he died of hyperthermia and dehydration. He was in solitary confinement. Now, this is not the first time this happened. I was monitoring it. I had actually, as a result of this, there was actually a defect in the air conditioning system, which caused it. Some of you may remember a few months ago, a man died of hyperthermia in the New York City jails, also related to a failure to observe and an HVAC failure where hot air was being pumped into an area. But this, he was 19 years old. He had not had his psychiatric medicines looked at he had not been seen by a psychiatrist for 3 or 4 months because the psychiatrist was on leave. I'm not going to show this here, but if you go on the web, you can look at death in Michigan 2006, and you can see the doctors and the nurses coming in to visit him. And I'm going to talk a little bit more about this in terms of dual loyalty in a few seconds. And it's just terrifying. And if I showed you the thing, it's really awful. And I have slides of terrible things that happen in prison, which I'm not going to show you right now. But very bad things happen, and this happened in particular because he was in solitary confinement, and the medical staff facilitated the use of solitary confinement. And in this case, he was restrained, he was tortured as a punishment. Period. So, coming to New York, from whence I grew up here. This is you're not supposed to apologize for bad slides. You're just not supposed to show them. But it's so the bottom line. The bottom line shows that in the first quarter of 2010, there were 720 solitary confinement cells, and as you can see, then 32 were added and they were all added for adolescents. So then you're up to 752. Then 159 were added, and a lot of those were another 32 of those were for adolescents. And then in 2011, another 32 were added for adolescents, and then from 720 to 1035 during a 3-year period in New York City, when everybody knew that solitary confinement was a bad thing. It's very strange. I'm on the Board of Correction in New York City, which is an oversight group of 9 people appointed by the mayor, the city council, and the judges of the first and second departments, which cover the New York City area. And we write rules which have the force of law. And we were complaining about this, but we were unable to stop it. We are now writing rules to severely limit the use of solitary confinement in the New York City jails, but they have not yet come out. But during this period in New York City, solitary confinement grew, and many of these people are seriously mentally ill. And a bunch of this housing is for people who are seriously mentally ill and have committed infractions in the jail, are identified as mentally ill, and therefore not allowed to be in regular solitary confinement, but in a special mental health solitary confinement. But the difference between the two is indistinguishable, and in fact, it's worse in the mental health units. And it's just a little bigger. And in 2012, in one of these units called called Maui, Mental Health Unit for the Infracted Inmate. This was the mental health unit. This is I was on vacation in Maine when I heard about this. It's again in August. Bad things happen in August in jails and prisons. It's very hot. Jason Echeverria was a psychotic guy. He had been in prison on and off, and in state mental hospitals from age 16 to his death at 23, I think. And he was this is on Rikers Island in New York City, just across the river, in the middle of the river there. There was a backup in the sewage system in the facility that he was in, and this is a unit for mentally ill people who are in solitary confinement. They were given buckets with cleaning detergent, which is some kind of lye, and he swallowed it, and then was in tremendous pain. A member of the medical staff, a pharmacy technician distributing medication, saw him. He was screaming. She went to the correction officers on site and to the captain and said, "Do something, about this." They did nothing. Through the night, they watched him, and did nothing. He was screaming. You can see on the tape that they're constantly going over to look at him. For some reason that's unclear, the power in that particular area went off at around midnight, so there's no film from midnight to 6 a.m. when he was discovered dead in his cell. So this is 2012. So why is solitary confinement a bad thing? It feels cruel. You give kids time out. It's not to make them feel good. It's to make them experience something that will have a negative will reinforce that they shouldn't do that. It's a negative reinforcement, and it's something we've always done. Right? We just put people in solitary, put them in a hole. We deny them human contact. Often denied a lot of stimulation of light, of sound, and people. So in 1983, a psychiatrist named Stuart Grassian, who's still working in this area, from Boston, as he was a psychiatrist looking at issues of sensory deprivation, was asked to review the situation of men in a psychiatric prison hospital in Massachusetts, and he interviewed a lot of people and wrote a number of articles which defined this syndrome of when you're placed in solitary confinement for a long period of time, you become hyperresponsive to external stimuli, you have hallucinations, you have panic attacks, you have cognitive difficulties, you have obsessional issues, you have paranoia, and problems with impulse control. And his work was very, very well received. It's consistent with everyone's thought about solitary confinement, and it identified a serious mental health problem. And when Judge Henderson agreed to remove the people of solitary confinement from the cells in California, it was based upon Dr. Grassian's work. And this is called the SHU Syndrome. Now, this is where it gets complicated scientifically. Dr. Grassian's work was, quoted in every federal court and in every course on this thing, but it was really based upon a quasi-science. He interviewed people who were identified for him. He was hired by the prisoners' lawyers to do this report. There were no controls, so a group of progressive psychologists and correctional advocates in Colorado decided that they were going to do the study which would prove that solitary confinement was dangerous. And this was funded by the National Institute of Justice. It was a study that used a natural experiment where you had a situation where there is not enough solitary confinement cells for mentally ill people in the state of Colorado. So you would go there or not go there based upon the availability of cells. And they identified two cohorts, one that was admitted to it and one that was not. And then they did a lot of standardized testing. I don't know they did MMPIs. We all have some familiarity. They had interviews, structured interviews. They had protocols. These were repeated every 3 months over a 2-year period, and the study showed that people who were placed in segregation over the first year did better than people who were not placed in segregation. So, Dr. Grassian wrote a scathing critique of the study, showing that the question, the instruments were bad, and this was bad, and that was bad. I mean, there were serious scientists who worked on this study. So the basic question is, you should know the answer before you begin a study, particularly if it involves, particularly what the consequences are. That's not true, but you just have to know that studies can go in different directions, particularly when we're dealing with these kinds of issues. So, this was a big deal that a very, very well-designed study did not show adverse effects of solitary confinement. Now, in fact, everybody in prison did badly. Nobody got better, but everybody got a little worse, but the rate of getting worse was slower for those who were in solitary confinement versus those who were in the general population. And so the people who did the study were very confused by it. Dr. Grassian was very upset by it, as were many people. And one of the main advisors to it, a good friend of mine, Jamie Fellner, who is a senior attorney at Human Rights Watch, who was on the advisory committee for this study, had trouble showing her face for a period after that. But it's not surprising, right? Is it that if you study something like this, that you don't know exactly how the data is going to come out? To me, it's not surprising. The result was surprising, but this kind of science this is what it showed. So, not much of a fast forward, but go ahead 4 years. In New York City right now, this place where there were more and more people being placed in solitary confinement during the period of 2010 to 2013, the Department of Health, led by Homer Venters, who was a social medicine Montefiore graduate, and that's an alarm? I can take it. Anyway, so a social medicine, which is one floor down, a social medicine graduate they have an electronic medical record, in New York City Department of Health. And they've actually published recently an article on human rights and the electronic medical record, because they have 100,000 admissions a year and have the capacity to review an enormous amount of data. And so they looked at incidents of self-harm within the New York City Department of Health, New York City Department of Correction, and looked at 200,000 admissions over a two-year period, and did multivariate analysis of it. And they did find that the incidents of self-harm, including events that could have led to suicide, as well as successful suicides, were much greater in people who had serious mental illness, were much greater in people who were in solitary confinement, whether they were initially, even whether they had been in solitary confinement before or after the event, and were associated with age as well. So that you actually can show, I mean, he was able to show using a large data set that there is a substantial association with self-harm, which is the most serious, one of the most serious, obviously to us as the outside, suicide is the most threatening of these issues. The pain that other people are suffering during their solitary confinement is a separate issue. So here in New York City, in response to the Colorado study, shows that there is a significant consequence, physical and mental health consequence of solitary confinement. So I think the science is up for discussion. What do we do about this? I think that was the subtitle of my paper. As you can see, beginning we began to press the Department of Correction towards over several years, but it was not until the end of 2013 that we began to get a this last August is an error. That should be 2013. This fiscally. Oh, so it's still. Oh, anyway, you can see that starting at the end of 2013, going through the first half of 2014, there was the last half of 2014. Sorry, this is wrong. This is August, September, October, November, December are 2013 years, and the rate of solitary confinement, the number of people in solitary confinement, has gone down on Rikers Island in response to the pressure from the Board of Correction and from community organizations which have made this issue and have talked about the Jason Echeverria and other suicides that have occurred. So there is something that can be done collectively in response to this thing, but although there was a significant decrease from the period, really this is July 2013 through December 2013. I'm sorry, let me do that. From July, from here to here, it goes down, but nothing has happened since since January. There's been no change since January. And so, although the de Blasio administration is on record committed to decreasing the use of solitary confinement as well as decreasing the number of people in jails, they have not done anything yet. We're in touch with them, and they want to do it, but they haven't done it. And so earlier this week, there was a meeting of the New York City Board of Correction, and I'm tooting my horn here, or whatever it's called. I'm the last word in this slide. There was a irrational action that took place on Rikers Island a month ago, where for no reason at all, in the middle of the night, the Department of Correction decided to move seriously mentally ill people out of their non-solitary confinement mental health housing into solitary confinement in the middle of the night for no reason at all. And the Board of Correction heard about it, and the Department of Health heard about it, and the rule and the policy, and the rule in terms of the Board of Corrections, we make rules, and the policy of the department is that you cannot move people into solitary confinement who are mentally ill without having them evaluated beforehand, and you probably can't do it. And in defiance and violation of that rule, there were 30 people moved into solitary confinement. So we had a discussion with the commissioner, about this, and it gets complicated because it's New York City. It's just off the record. It's it's the summer of 2014. There's a progressive administration in town. One wants to be supportive of it. They're committed to decreasing solitary confinement, and yet their new commissioner did this. So it's a politically sensitive moment if you think about it, how one makes change in absolute practice. Now, back in Chicago, going back again 20 years, and I'm talking now really about sort of issues of dual loyalty and things like that. A friend of mine, actually the first resident, when I was an intern in July of 1975, and he was my resident. He was the medical director of the Cermak Health Services, which is the Cook County Jail Medical Program in 1992, and as you can see, he examined a Mr. Wilson who had multiple bruises, swellings, and abrasions, battered eye, and several linear blisters on his right thigh, right cheek, and anterior chest, which were consistent with radiator burns. He stated that he had been cuffed to a radiator and pushed into it. He was one of many people who presented to Cook County Jail with linear radiator burns or cigarette burns or other marks of torture, which had taken place in the police stations, and one particular police station in Chicago during this period. And what's amazing, not amazing, but what's significant is that he wrote this letter. You could imagine being a doctor in a prison or jail and seeing something like this happen. Not often, but just seeing it, knowing that you could not explain this is a Kebner phenomenon or something. You could not explain why someone would have linear burns on their chest without thinking, thinking about why they had linear burns. But Jack wrote this letter, and I don't know if any of you are from Chicago. This is 2011. So 20 years later, the guy who did that was finally put in prison. But I put this slide in because it's a doctor doing the right thing, and our capacity as doctors to do the right thing is a privilege that we shouldn't forget, that we have to exercise, and change happens slowly. But we can all imagine, I imagine, that this was not the first time this happened. Other doctors in Cook County, jail had seen linear burns, and doctors throughout the world and throughout this country have seen torturous behavior, like Timothy Souders that I showed before. And the doctors were there every day checking to see whether the so it just says so I'm going to come back to that again in a second. Just keep in mind that terrible image. So in 2012, I'm now back to the beginning. I'll go quick now. 2012, a new lawsuit was brought in Pelican Bay, and actually I went out to Pelican Bay and interviewed 10 prisoners who were the named plaintiffs in this case. These people up there, I talked to each one and examined each one of them. There's a new suit that's been brought on behalf of the people who were in solitary confinement in Pelican Bay who are not mentally ill, and the class of people in the suit are people who have been in solitary confinement for more than 10 years. And what's the number? How many people is that? 512, 520. Over 500 people in solitary confinement for more than 10 years. And so the lawsuit, which has actually survived a number of points in federal litigation, the judge is allowing the lawsuit to go forward, it has to prove that there's a consequence, a medical consequence to being placed in solitary confinement for more than 10 years, even if you're not mentally ill. And that's a difficult burden. And actually, if any of you are interested in reviewing medical charts of these prisoners, you can contact me, because I have access to all of them, and we're trying to help the lawyers see if there's something. There may not be anything there. It's wrong whether or not there are medical consequences, but I don't know if there's anything there. Anyway, I want to leave I want to leave more than this for questions, but I didn't. So I've talked about a number of issues today, a little, I hope not too disjointedly. Talked about dual loyalty, the responsibility of a health practitioner in one of these settings to their patients versus to the institution. Lots of quality assurance mechanisms in prisons have as the object the institution, not the patient. And I'm interested in the answer to the following question. If the unit of interest in a quality assurance project is of value to the community, is that different than if the unity of interest in a quality improvement or insurance project not of value to the community? So, for example, if at Mount Sinai you're trying to make sure that everybody does as well as possible in whatever area you're looking for, and everybody really feels that, except for nobody, that everybody is of value. Versus doing a quality assurance project where people are not thought to be of value. For example, doctors and nurses who work for a long time in a jail at Rikers Island will ask, how many bodies are there in the receiving room? Now that's a little bit equivalent to you saying, how many acutes are there? Or I don't know what the linguistic component would be, but it's different when you say bodies. So that's just an issue that I raise, and I'd be interested if any of you are interested in that. And I mean, I've seen it functionally. There's a National Commission for Correctional Health Care. I was on it for 17 years. It accredits jails and prisons throughout the United States, and it's accredited a lot of terrible places. And for 20 years, it never interviewed a prisoner. It never looked at a medical chart. It just looked at policies and procedures. So I think I'll just, there's no conclusion. There are too many people in prison in the United States. It's way different than it is in other countries. It changes politically over time. It doesn't have to be this way. As I think I've shown a little bit, healthcare practitioners, particularly doctors, can really make a difference in this in terms of identification of overwhelming problems, as well as the day-to-day stuff, which I didn't talk about at all, which is very complicated. I'd like to take questions if there are any, and
I mean, they obviously ignored the guy. What difference does it make if he was in solitary or not?
Oh, it didn't. I mean, the only the advantage was that I got to see the video because I had access to it because only solitary was being videoed. No, you're absolutely right. It could have been anywhere. But the notion that you would be placed in, I mean, he was in solitary and in 4-point restraints. So that putting people in prolonged restraints. No medical care. Oh, absolutely. He was definitely killed by no medical care. Absolutely. And it just happened to take place in solitary confinement. But there was a pattern in Michigan of people in solitary confinement sort of wasting away, being psychotic and not eating, and so it is an example, I think, of. It exacerbates the lack of care. They knew exactly what was going on. He was on all these medicines. I mean, he did not. He was. They watched him die. And they could have stopped it. Other questions? Yes? Yes.
And I was wondering if you might be able to touch briefly upon any changes that you're seeing in providing access to drug and alcohol treatment in prisons.
Yeah, there's not much. I think there might be some right now because apparently white people use heroin. New York City has had at various times has had methadone maintenance. Rhode Island initiates methadone maintenance for people, and I think provides buprenorphine. New Mexico tried to provide methadone maintenance. Up until recently, many prison systems were really bad, where if you came in with an opiate addiction, you were given hydroxyzine and Maalox as a treatment. So the answer is there's not a lot. I mean, it's not even universal in the United States for pregnant women who are on opiates to be given the opportunity to take long methadone and buprenorphine for the last trimester. I just heard of a case of someone in Texas who was actually on a methadone program and was taken off when she was put pregnant and put in jail. Neil?
So with 1 out of 3 black men going to prison, we obviously in our practices see a lot of people who've either been imprisoned 1 or more times.
So, what kind of things could we do in the community? Number one, what should we be asking about people's treatment when they were in prison? And if we identify things that were problematic, like that doctor whose letter you showed, who would we write to? I mean, is there a role that we can play that would be progressive in any way in relationship to, helping to fix these kinds of problems?
Yeah, there is a movement right now. It's not a movement. I mean, there are things called transition clinics. The first one was set up in San Francisco about 5 or 6 years ago. There's one in New Haven. There's one in Cambridge. There's one in the Bronx. For where basically it's usually started by residents and medical students, but a clinic which identifies people coming out of prison, which has a relationship with the, usually for prison rather than jail, although it could be done for jail, which identifies people living in the community and provides some social work support to help them get integrated into the medical care system on discharge. This is now no longer a burden because ACA will cover these generally men. Right now, they weren't. So I can get you in touch with nationally the group that does this. They publish their work. It began in San Francisco as part of the statewide litigation in San Francisco, which has actually closed down about 30,000 prison cells in the state of California because the Supreme Court ruled that people were dying due to overcrowding, which caused lack of access to medical care. That's a story I did not show today, but they're much clearer one. Also had to do with tremendous medical incompetency, but related to the enormous size of the prison and their inability to get adequate medical care. So the answer is yes. For people being discharged, there are models of support for them. I think it's important that people get integrated back into usual care rather than being in such a situation for so long. But that's a bias, which may not be right. But I think there's a lot to be done there. People are discharged with medication. They do need care. There's obviously an enormous reservoir. I don't know what the right term. Hepatitis C in prisons in the country. 20 to 30% of state prisoners are infected with hepatitis C. Other questions? Yes. Yes.
The patient, or regarding the prisoner that was on 4 points restraint. What do you think in terms of the physicians? As physicians, we think that we would give the best care, or we regard ourselves in a higher moral code, but these physicians didn't speak up. So why do you think they honestly didn't think there was anything wrong, or they were afraid to?
Well, I think that this is the notion. This is the issue of dual loyalty. People sort of, I think, it's hard to understand, but these doctors and nurses were following their protocols. They were visiting. They were visiting the person in solitary confinement every day. They did not question the use of 4-point restraints. I mean, I think we probably almost everybody in this room would question the use of 4-point restraints as a punishment, which is how it was done. You question the use of 4-point restraints for someone who's demented or who's seriously mentally ill. You want to make sure they're in it for as short as possible. You want to make sure that they're evaluated by a clinician constantly. So why do people act that way? I don't know. I think one of the things that I think, as Neil began his introduction to me, you need a posse, sort of. I think you need to, in situations which are complex like that, like this, and where you're isolated as a clinician or as a physician in a jail that it's very hard to operate by yourself. You really need to. It's very important to be able to talk to other people about what you're experiencing and questioning it, because I mean. I don't think that this doctor spoke to who was examining Timothy Souders, talked to any other doctors about it, and maybe if he had, they would have all agreed that it was the right thing to do. But I think to the extent that you perceive something wrong, then it's wrong. So Guantanamo, force feeding. Is it the right thing to do? Is it the wrong thing to do? I mean, there's use of torture in Guantanamo in terms of psychological. In terms of interrogations, which is an issue medical staff did not get involved appropriately. At Abu Ghraib, there were issues about physician participation in this. So this is a real question. Why doctors don't always act correctly. I do want to say one other thing, which is not exactly on point, but that the reason not to put people in solitary confinement, to me, is not because it hurts you medically. It's not because there are mental health consequences of it. It's because it's wrong. And so science is very important, but the ethical issue here is deontological. It's not about what the consequences of the thing are. It's about the fact that it is wrong to treat our fellow humans that way, I would say. Yes. Well, let me just ask someone else. Yes.
Getting rid of the boxes on employment applications.
Right. Block the box. I mean,
Block the box. Yeah. Can you speak to that and whether that's related to Neil's question about what can we do?
Oh, yeah, no, it can be. And there may be some people working on that here. I know there are at Montefiore. There's a project of the social medicine program to block the boxes. Routinely around the country, there are in employment applications that says, were you in prison? And it becomes a screen. And so if you take that out, it may be that the fact of imprisonment makes someone ineligible for a job for some other reason, but it allows them to get past the screen. And I think it also raises tremendous discussions internally with human resources about what their role is. And particularly in New York, where so many people have been in prison, every place, you can't begin to address the issues of racial discrimination in employment without addressing that issue. So I think it's a very important thing. Yes.
So in our clinic, we service a lot of women and families who come from alternatives to incarceration programs like Green Hope and Odyssey House. And in speaking with these women, we learn a lot about what their experiences are and how frustrated they are with the lack of access to mental health care services they get in those programs. Is anything being done to increase access to mental health care services?
Well, there's a task force that was just announced by City Hall 2 weeks ago on mental health and criminal justice. So there's a lot of people are in it. There's going to be a lot of money. I don't know where he's going to find it, but there's a clear recognition locally that this is a big issue. As to where those services should go, at the Board of Correction meeting on Tuesday, a woman whose son was incarcerated upstate and is currently in prison, had been on Rikers Island for a long time, said, because the city budget just gave another $35 million to Rikers Island, half of it for mental health services. She said, you should be ashamed of yourselves, because the money should be spent to not put mentally ill people in jail and putting it in, you shouldn't be incarcerating these people in the first place. So it's complicated, but the answer is, in New York City, there's a lot of discussion about it right now. And if you're interested, I can get you in touch with the task force. Yes. Yeah. 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 Well, Africa is much, much lower in general, except for Rwanda. Rwanda is a very high rate of incarceration. It's about 500 or something. But the rest of Africa is extremely low. China is very high, but the rest of Asia is pretty low. China is in the 500 range too. Russia used to be above the United States. It's going down into about 400. So that other slide has so many countries on it that I didn't do it. But you're right. So the answer is the United States is from 700 to 200. There are very few people. It almost all goes down. 200 per 100,000. So this would. I'll get you the slide. Yeah. Oh, I think that's a critical issue. If you try to answer the question why, which you're asking, I think heterogeneity is a critically important issue. I mean, in Norway the rates are in the 30s or 40s, and if you can imagine anybody in prison being your cousin, you're going to be a little less likely, except for some of your cousins, to want to put them in prison. So I think heterogeneity is critical. Race is critical. The religious underpinnings of this country, in terms of our where prisons come from, and the way Protestantism has worked in this country, are very important to it as well, in terms of a punishment and another religion, all religions, in terms of an ethic of punishment. has been important. But it's worth to get it down. It's definitely worth answering the question. I agree with you that heterogeneity versus homogeneity is important. Doesn't excuse it, but it's important. Well, thank you so much. Really, really, thank you.